Hi, my name is Kenneth Shaheen. I'm a plastic and reconstructive surgeon at Beaumont Hospital. I'm a clinical assistant professor at Wayne State University and an associate professor of surgery at Oakland University. I'm the division chief of plastic surgery at Beaumont Hospital and have been practicing for over 20 years. Among the procedures we perform in our practice are breast reconstruction, and that's what I've been asked to discuss today. So the goals of breast reconstruction are to recreate the breast mound and the nipple areolar complex, which is present in the normal patient. During a mastectomy, the nipple and areola have traditionally been removed as part of the mastectomy, and the most common incisions used in mastectomy are transverse or sideways across the breast. We have a breast model here that demonstrates the typical incision across the center of the breast that's used for mastectomy. Typically, in most patients, the nipple and areola are removed, so this represents a straight line. At a staged procedure, after the breast mound has been reconstructed and to the right size and shape, a nipple and areolar complex is reconstructed through separate procedures. Traditionally, this has been done through a variety of techniques. The most commonly used technique is a modified skate flap. The skate flap involves elevating two pieces of tissue from the side, and those tissues are folded centrally to form a cylinder, and then the top piece of tissue is placed on top of the cylinder to reconstruct the papule, and then a skin graft is commonly placed around the papule to reconstruct the areola. After this is done, the nipple areolar complex will typically shrink approximately 50% over a period of 3 months postoperatively. If it has mechanical pressure on top of the areola during that period of time, the nipple and or areola may not take, and you will end up with a flattened nipple or a failed reconstruction. To prevent this, surgeons have developed a variety of techniques to protect the nipple during the healing phase in the first 6 weeks to 3 months. The most commonly used device is the flange off of a syringe, and this syringe is rigid. It has to be taped to the breast over the nipple reconstruction and held in place. It's uncomfortable. It places undue pressure on the skin graft and the nipple. It can move easily. It's visible through clothing, and so it's been an imperfect design, and this has led to the need for other forms of protection for the nipple areolar complex.
Okay.
We have made application for the Recontour the nipple guard and scar therapy device, and we have been compared to several other devices that are currently on the market, and today we're going to demonstrate what those devices are and how they differ significantly from our product. The first device discussed was the Schindler device. The Schindler device was a cup-shaped device used on a normal breast, had nothing to do with reconstruction or surgery, and this was used designed to disguise the nipple in people who did not want their nipples visible through their clothing. So it had no other function other than to cover the nipple and make it not visible under clothing. The second device compared is the Clark device. And the Clark device is a rigid core that is placed over the nipple areolar reconstruction. It has a hollowed out central core. It's covered in an adhesive cloth gauze or a cloth tape that fixes it to the breast. Because this device is rigid, it does not comply to the contours of a breast, and it is quite visible over the, or quite visible in clothing. So when this is on, this device can be seen when the person is wearing it. The other differences are the cloth adhesive tape. This is a one-time use device, so once you put it on, when you remove it, it cannot be reapplied as it's designed. For the average person who showers daily or every other day, that would mean removing the device, taking your shower, and putting the device back on, or putting a new device back on. And those multiple applications of tape on and off the skin over long periods of time have a high incidence of dermatitis and skin tears. So this makes this a difficult device to use on a practical basis for extended periods of time. The other aspect of this is the back of this is rigid, and it has a rim around it. When you reconstruct an areola and you have a skin graft on there, you do not want a ridged device that is going to put uneven pressure on your skin graft. You want even pressure that is uniform throughout its design, so that it does not place undue pressure on a fresh incision or on the areola. An additional feature of this device is the fact that it only functions as a device to protect the nipple. It provides no additional benefit to the healing incisions and absolutely no benefit to the mastectomy scar or the incisions around the areola, which are part of the reconstruction. If this were applied to a reconstructed breast, it does not cover any of the mastectomy scar and does not provide any additional benefit to the incision around the areola in terms of wound healing or scar therapy. The recontour device is designed to provide protection to the nipple areolar complex, as in addition to provide scar therapy to the surrounding areola and mastectomy scar. This device is a one-piece design. It does not require assembly. It requires no adhesive. It can be placed into a bra. It is not visible under clothing. It can be used throughout the patient's entire reconstructive postoperative course. So the same device can be used over and over again and does not have any difficulties with the adhesive dermatitis that's common with multiple applications of tape on skin. It can be used post-operatively. It's designed for the post-operative use, and this particular device will cover most of the mastectomy scar as well as the areola at the same time. It is pliable, so it will conform to a normal reconstructed breast regardless of its shape. And where this Clark device is rigid and cannot conform to, the breast has to conform to the Clark device. In the recontour device, the device will contour to the reconstructed breast. Recontour device is made of medical grade silicone. Medical grade silicone has a long history in scar therapy and has been scientifically proven to improve scars both from the mastectomy itself as well as from the areolar complex. So again, this provides not only protection to the newly reconstructed areola, but it provides therapy for the incisions around the mastectomy site. The Schindler and Clark devices require adhesive to hold them in place. The recontour device can be used with adhesive, but it is not required for proper application. Following the nipple areolar reconstruction, there has not been a device which satisfies all of the requirements in a postoperative patient. The Schindler device was designed specifically for coverage only and has no role in a reconstructed patient. The Clark device is a rigid device that is a one-time use, requires adhesive to apply to the skin every single day until you're through using the device, and it provides no uneven pressure to the nipple areolar reconstruction site, and has a cloth backing, so there's no scar therapy in this device. I would not feel comfortable using this device in my current nipple areolar reconstructions. The Recontour device is not visible, it's reusable, it can be kept clean because of its design with the medical grade silicone. It provides excellent protection to the nipple in addition to scar therapy for the areola and mastectomy sites simultaneously. It can be used throughout the entire duration of the postoperative course, and contours to the reconstructive breast instead of having the breast contour to the device as in the Clark device, which is rigid. The breast, in this case, this device will contour to the shape of the breast that we've originally designed.